Good afternoon, everybody, and welcome to this patient-focused webinar. My name is Dave Burns, and I am with Insight Tech, and I will be one of your co-hosts for today's event. And I'm pleased to be able to welcome all of you. I ask that you be patient as we take a few moments to allow everybody to get registered. We have had a phenomenal turnout, and that's kudos to all of you. So stay tuned. Our presentation is going to begin shortly. Thank you.
I think we have a good number of people signed on, Dave Burns. You can go ahead and get started.
Very good. So again, welcome everybody, and thank you for your concession of time today. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Greg Bonnin from Houston Physicians Hospital, as he is going to discuss focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise, and we encourage you to compile those, please utilize the Q&A button located at the bottom of your screen. Describe your question. And what we will do at the conclusion of the presentation is try to answer as many of those questions as we possibly can. So please take advantage. I want to begin by introducing our presenter, Dr. Greg Bonnen. Dr. Bonnen is a board certified in neurological surgery by the American Board of Neurological Surgery and a fellow of the American Association of Neurological Surgeons. Dr. Bonnen also serves as chairman of the board of Houston Physicians Hospital, located in Webster, Texas. Just a brief biography of Dr. Bonnen. He grew up in Angleton, Texas, and graduated cum laude from the infamous Texas A&M University, Gig'em, and with a Bachelor of Science degree in biochemistry. He earned his medical degree at the University of Texas Medical Branch in Galveston, and he also completed his internship and residency there as well. He served for 2 years as an assistant professor of neurosurgery at UTMB. So it is my distinct pleasure and honor to introduce Dr. Bonnin for today's presentation. Dr. Bonnin, it's all yours.
Well, thanks, Dave. And so what we're going to do is we're going to talk about focused ultrasound and its role in treating tremor, both people that have essential tremor and also tremor-dominant Parkinson's disease. And I want this to be interactive, so we're definitely going to take questions. But there are a lot of questions that we get commonly, a lot of frequently asked questions. And so by taking a little bit of time here to give you some of the background, I think some of those more commonly asked questions will hopefully be addressed. And then after that, we'll move on to those things that we haven't managed to cover. So we're going to start by talking just a little bit about essential tremor and tremor-dominant Parkinson's. And we can go ahead and go to the next slide there. And so, what is essential tremor? Essential tremor is a scenario where people have difficulty with tremor, and it is the primary symptom that they have. So they don't typically have other problems as a consequence of their essential tremor. We don't know exactly what causes it. Some cases are hereditary, but many are not. And it can gradually over time become so severe that it interferes with just simple daily things like being able to feed yourself, get dressed, brush your teeth, things that we normally take for granted become a real chore. And that is something that we are now able to treat. Tremor-dominant Parkinson's is a little bit different in that people may have a pretty profound tremor that really does interfere with their quality of life, but the underlying condition is a different underlying problem, and they may have other symptoms like rigidity or difficulty with motor coordination, things of this nature as that disease progresses. Both will respond well to a focused ultrasound thalamotomy, which is what we're primarily talking about today. And I'm going to give you a little bit further background in that many of you have probably been treated with medications. You've perhaps been offered something called DBS or deep brain stimulators, which we can place into the brain. And then now we have focused ultrasound, which has become really appealing because it doesn't involve making an incision or drilling a hole or putting anything mechanically like a probe or an implant into the brain. And I'm going to give you a little bit of a history, and that is that what we're actually doing is a very new, exciting way of doing something old. So if you go back to the 1950s, the first treatments to target the thalamus, this part of the brain, were actually done back decades ago. But as you can imagine, the technology was not what it is today, and it was very invasive, and side effects and possible complications were greater. And then over the years, people have tried other technologies to achieve the same thing, which is essentially knocking out a little population of cells about the size of a pea in a relay station that will allow for relief from or alleviation from the tremor. When I first got involved in treating patients with essential tremor and Parkinson's, it was 1995. And we actually were doing things what I would call the old-fashioned way. We would make an incision, drill a hole, put a radio frequency probe down to the target, warm it up a little bit to test the results, and then we would actually heat it up to ablate that little population of cells. And then if you fast forward a few years into the early 2000s, we got approval for deep brain stimulation in the United States, both for essential tremor and Parkinson's. And we would put essentially these pacemaker type devices into the brain. And there are other targets in the brain that we could use them for if you had Parkinson's versus essential tremor. And that became really the gold standard apart from medications. And so now with focused ultrasound, the big fuss, if you will, and you can go to the next slide, is that we don't have to actually make an incision or drill a hole or put anything into the brain to achieve a very similar and dramatic outcome. So there's no general anesthesia. It's an outpatient treatment or procedure. We do it in the MRI suite, and patients see an immediate result or outcome. When I was first approached about doing it, I was a little bit skeptical because I thought, well, DBS is really good. The implants work well. They have the advantage of being able to do them on both sides. We can target other areas for other processes if we need to, and they're adjustable in the office. However, there are so many patients that simply are not willing to consider an invasive procedure, or maybe they're medically fragile and anesthesia is just not a good idea for them. And as it turns out, there's a whole population of folks that are living with their lives being impacted every day by tremor that would not consider an invasive treatment, but they will consider this. And then we got into doing this. We started in June of 2021, and the results exceeded, frankly, my expectations for what it would be. And the ease for the patient and the quality of the outcomes has really been rewarding. So that's what a lot of the excitement has been. If you have essential tremor, know that you're not alone. There are there are millions of people that live with this. And one of the frustrating aspects of it is that the medications like beta blockers, say propranolol, primidone, other medications that are used are typically not very satisfying. So they help a little bit in some cases. They don't help much at all in other cases. And that's why people turn to some type of procedure, whether it's focused ultrasound or DBS, to get relief. And you can go to the next slide. So this just covers a little bit of what we just talked about, which is medications are an option. Sometimes people will wear devices that are weighted, like weighted gloves in their utensils that are specifically crafted to help people mitigate their tremor. But a lot of these things just don't give you back the quality of life that people really are looking for. And that's what leads us into this far right category of focused ultrasound in DBS predominantly. The radio frequency would be back what we were doing in the 90s, for example. Stereotactic radiosurgery refers to using focused radiation to ablate an area. And that's certainly not something that's common in my practice. There may be some people doing it, but predominantly it's now focused ultrasound or DBS. You can go on to the next slide. So here's some key milestones with respect to focused ultrasound. We get asked a lot, how long has this been around, and how many have been done? And as you can see from here, that FDA approval is about, maybe 7 years old now. Medicare decided to start covering it, which is, of course, very important in terms of people simply being able to access the treatment back in 2018. And Medicare is typically a trendsetter for the other payers. So once Medicare will cover something, the others will typically begin to follow suit. And we'll talk about that again briefly in a few minutes. It's also approved for tremor-dominant Parkinson's now. It's been approved for patients with Parkinson's to treat a little bit different location in the brain. And that's something that I have a little experience with, and I'm looking forward to maybe doing more. But that is something that at this time, I think we only have approval for one side for patients with Parkinson's, and we don't have as easy a time getting that covered by the payers yet. And then the big, more recent development is that starting just this year, we're now able to treat the second side for patients with tremor. So if you think about it, a lot of people have tremor really bad on both sides. And in the beginning, we could treat one side, but we didn't have FDA approval to come back later and treat the other. So the way that works now is you can't do both at once. And there are medical safety reasons for not doing both at the same time. But with a minimum of 9 months, we can come back and do the second side 9 months or more later. And we have good experience not only with clinical trials, but in our practice here at Houston Physicians, we've now done a good number of those, and they've actually gone a little bit easier than the first side. And I think that's predominantly because people know what to expect. And so it's an actually easier, less stressful experience. You can go on to the next slide. So how does this actually work, and what are we doing? It's using sound waves. And if you think about it, the way this occurs is there's essentially a semi-circular or spherical shaped helmet, and it emits sound from up to 1,024 channels. In a given treatment, we'll have about 950 to 1,000 of them. And any one of them doesn't necessarily do a whole lot, but if you have 1,000 of them active, and they're all aiming at the same place, coming from different angles in different directions, where they all converge in one tiny location, it'll create heat. And we can actually control the amount of heat and the length of time. And that's what allows us to do this without making an incision or placing anything into the brain. And the results are right away. So when we're actually doing the treatment, we're literally talking to the patient and having them demonstrate their ability to draw spirals and straight lines and to hold a bottle and things of this nature. And you can actually see the improvement during the course of the treatment. You can go on to the next slide. So who is suitable? This gives you a little bit of a picture of who can be treated. And there is a minimum age, if you will. Of course, the reality is most of our patients are well older than 22 years of age. Now, a lot of people will tell us they've had tremors since they were a teenager or even younger, but it's just slowly, as the years and as the decades have gone by, become worse and worse. But the average patient is definitely much older. There's a minimum age. We have to document that you've made a good faith effort to be treated with medications and that they're not adequately controlling the tremors. The procedure is done in the MRI suite, and so we've not had anybody who couldn't tolerate being in the scanner. Even people that are claustrophobic seem to be able to do well with this procedure. You're not actually in the scanner the whole time. The longest length of time that a patient would be in is about 10 minutes, and then they slide out from being inside the bore of the scanner. But we do this with the patient awake and with, in our case, essentially no sedation. And then we do have to be able to communicate with the patient because we're asking for feedback as we're getting everything lined up and positioned just optimally for where we want it to be. There is a stop sonication button. In other words, it's a little ball that you can squeeze. And so if the patient's anxious or anything is happening that they're really concerned about, and usually we worry a little bit if they're getting too nauseated, although most patients don't have too much trouble with nausea. But if you do, you simply squeeze the ball, it stops everything, and we come in and make sure that the patient's okay. Obviously, because it's in the scanner, you can't have any implant that would not be compatible with the scanner. Fortunately, today, even most pacemakers are MRI compatible, and we've had a number of patients with pacemakers that we've been able to manage, but that's a requirement. The skull density ratio, interestingly, we have to take a look at the anatomy of the skull because sometimes, and this isn't super common, but sometimes we'll have patients that the sound waves just can't make it through the skull efficiently enough to deposit enough energy and create heat at the target. So it's not dangerous, but it would make it so that we couldn't generate the type of benefit to the patient that we want. And so we'll look at something called the skull density ratio, which is a really helpful factor, but it's not the only one. We'll also look at the thickness of the skull and the shape of the skull. And we're really just wanting to make sure that there's a reasonably good chance of success with doing it, which is almost always the case. But we've had a few people where we looked at the skull and just said the density ratio was too low and the thickness and the other factors just suggested it just wouldn't help them. And in that case, we're not able to do it. So that's something that we do up front before bringing somebody in, for treatment. And you can go on to the next slide. So a lot of procedures have been done now, and that's another thing people like to know is there a lot of experience? And so the numbers that you're seeing here are cumulative for all the doctors and patients that we have experience with. At our facility, we started, as I think I mentioned earlier, in June of 2021. I believe we were actually the first in Texas to do this type of procedure with this technology. And we've done over 230 cases now. And so we've really had an excellent experience with doing it. And from my perspective, having been involved in doing surgical procedures for Parkinson's and tremor for almost 30 years, it's just another tool in the toolkit, if you will, and not something that is new in the sense that we haven't been treating patients for this problem or doing surgery for this problem, but it is a really exciting new way of doing it. It's much easier on the patient and is proven to be highly effective. And as you can see, there are thousands, now tens of thousands of people that have benefited from having this treatment. So you can go on to the next slide. So another great question is, well, how long is it going to last? And then also, what kind of side effects, could I have if I have this done? And what you're looking at here refers to specifically focused ultrasound. I personally think you can also draw a little bit on the experience from doing thalamotomy, what I would refer to as the old-fashioned way, because it really is simply a different technique and different technology for doing something that we've done for a long time. And we know that for most patients, there is still a very substantial benefit 5 years after the treatment. And for some people, it's much more than that. And now part of it, to get a little bit into the weeds, is not simply the treatment wearing off, but if you think about it, if you've had tremor for many, many years, you know that it gradually progresses. And so as the years go by in the future, it may continue to progress. And with this specific treatment, it's very fixed. So once we do it, we don't turn it up or down unless we were to go back and do it again, which is actually possible. So if the underlying process that causes the tremor is slowly progressing, you eventually may actually have some residual or recurrent tremor. It may not be as bad, but I think if you live long enough and enough years go by, it will eventually return. Anecdotally, I have one patient now that had an old-fashioned thalamotomy in 1994 when he was in his 40s, did beautifully, went back to continue working actually as a general surgeon, believe it or not. But 28 years later, the tremor had returned. He was retired, and it was just interfering with normal day-to-day life. And we did a focused ultrasound thalamotomy in the exact same location as he had had the radio frequency probe thalamotomy done in 94, and he did beautifully. So we don't have a lot of repeat patients at this point, but I do have an experience from somebody that as long ago as 28 years has been successfully now been treated with a follow-up treatment. Side effects are really important to know about. We're essentially using heat. And if you think about it, the technology is able to deposit this heat very precisely and only at the target. But it's not so precise that there is zero heating around the target. So you may have a little bit of warming, not to the point of damaging the tissue, but a little warming, a little swelling in the area around it. And that can lead to side effects. Not everybody is going to have them, but the most common thing that our patients will describe is feeling a little bit unsteady on their feet. And some will say they feel like they list to the side that was treated. So if we treated the right side, they'd feel like maybe they lean a little to the right, or if it was the left side, they lean a little to the left. And that's about 1 out of 4. So 74% of the time, that's not going to happen. But for those that do, it will typically get better in the days and weeks after the treatment as the swelling in that area goes down. Numbness and tingling is another common one, and that can be, well, it would be only on the side we treated. It can be in the fingers or the hand, or in our experience, even a little more commonly, if that happens, it would be in the lips or the tongue on that side, which is kind of interesting. And again, it is almost always transient. So it's unusual that we would have anybody that would have that long term, but that is a common thing that we may see immediately after a treatment. Headache and head pain is not something that we have seen as frequently as what is listed on this slide in our patients, other than you may definitely feel that during the sonication, which is when we're actually delivering the sound energy, which is a matter of seconds. It's less than a minute, but that typically resolves pretty quickly afterwards. So that's just a little bit of an overview of some of the things that you might experience. On occasion, we may have somebody describe that they feel like their speech is a little bit off. And a lot of the time, the patient will describe it and the people around them don't notice. But the patient is definitely aware that their effort is a little bit different to get the same words and the same volume of speech out. So that's uncommon, but we have on occasion seen that. You can go on to the next slide. So let's talk real quick about what is this experience like if you were to actually have it done, and what do we do? So it's an outpatient procedure. You would not be admitted to the hospital before or after. You come in on the day of the treatment, and we do have to shave your hair. So we take the patient to the preoperative area, and people say, well, why do you shave their hair? Well, it's not because that's my haircut. Okay. We do that because your hair will actually interfere with the transmission of the sound energy. So we shave the hair, and then we numb the skin with a local anesthetic on the right and on the left, in the front and in the back. And then we'll go to the MRI suite. When we get to the MRI suite, we'll place a stereotactic head frame. Now, in previous years, and even now, those frames are often used in targeting. We'll actually calculate geometric coordinates based on the frame as reference points. But in this case, we're using the frame quite simply to keep the patient's head perfectly still. We're targeting a tiny area. It's only a few millimeters. And so obviously we don't want you to cough or sneeze or scratch your nose and you move your head. And of course, people have tremor. Many people have tremor in their head and they can't control it. The good news is the frame works beautifully, and we've not once had a patient have a problem with movement during the procedure. So that's the whole purpose of the frame. Then the patient is positioned on the MRI table. The ultrasound transducer comes down and fits just over the upper part of the patient's head. And then we do the actual procedure, which in the beginning pretty much involves just taking some pictures with MRI. And then we're doing a lot of work on the computer. Once we get that calculation and setup done, we'll actually have the patient do drawings and demonstrate their tremor while they're lying on their back in the scanner as a baseline. And then we'll do some of the initial sound treatments. And those initial sound treatments will vary in length from 11 seconds to maybe 20 seconds. And that really depends on the efficiency of the skull. But as you can see, they're very brief. So a long initial sonication would be 15, 16 seconds. And I'll typically do 2 or 3 of them with the purpose of simply confirming that we've got everything lined up the way we want it. And then we'll get to a temperature that's not hot enough to create anything permanent, but it is warm enough to begin to see an effect. And then we can have the patient draw again and hold a bottle again and see, have we achieved some improvement and are we on target? And we can also look to see if they're having any side effects and do we want to adjust the target. Then when we've got that to a place where we're comfortable, we'll do typically 2 additional sound treatments that are, again, on the order of 11 to maybe 25 or 30 seconds, which would be a long sonication in our experience. And those are intended to make the improvement permanent and to make it as good as we can make it, which I used to tell people we're shooting for 60 to 95% improvement in the tremor. And pretty consistently, we're getting 90% and above at this point. And you'll actually see that when we do these final 2 sonications. At that point, we're done and we get the patient up off of the scanner. They will walk to a chair, sit down, we'll remove the head frame, and then we take them to a room where they visit with their family for about 30 to 45 minutes and go home. The whole time for the procedure in the MRI suite is about an hour to hour and a half. We've had some as quick as 45 minutes. We've had some last a little longer. And a lot of that, again, comes back to the efficiency of the skull. You can go on to the next slide. So this just speaks to the benefits. Obviously, no anesthesia is really nice. No incision, nothing implanted into the body. We've never seen one of these become infected. It really does improve patients' quality of life. And it's just an easier experience from the standpoint of the patient. You can go on to the next slide. Insurance is really important. And something I would tell you is that we don't schedule this without having checked with whoever it is, whether it's Medicare or a commercial carrier ahead of time. And the good news is that we really have not had a hard time getting insurance coverage. And we want, of course, to know up front what the case is going to be and if it's covered, and whatever the patient's copay or deductible or obligation would be, we always make sure that people are informed of that before we actually do anything. You can go on to the next slide. So the second side, that's a really good question. And there are some of the label indications, I guess, if you will, for doing the second side. The key for us is what was already mentioned, and that is we do have to wait 9 months. And of course, by definition, patients are coming back for the second side because their opposite side is really affecting them, and they had a good experience with the first side that we did. You can go on to the next one. And this is just some of the clinical trial results that were done demonstrating the efficacy of doing the opposite side, which again is in my view, it's not substantially different than doing the first side. It's gone really well. It's a little bit easier, but the side effects are essentially the same as in our experience as doing the first side. Go to the next slide. Yeah, and so this is more information on the trial that was done. You can go ahead and go on. Yeah, and I guess one other piece of information I would give to you that we're commonly asked is follow-up. And we have a lot of patients that don't live in the Houston area, for example, and so we've had to adapt and become rather adept at getting to know people and getting a clinical evaluation without them having to come to Houston. Of course, you have to come if you're going to have the treatment. And then we call people the next day. We typically do an MRI the day after the treatment, actually. And then people will return home and we follow up with them in 2 weeks and then again in 3 months. People are always welcome to come for an office visit, but that's not typically required in our experience. And with that, that's just an overview of some of the basics, and I'm happy to take questions.
Dr. Bonnen, thank you very much. And we've got a great enrollment of participants today. We've got some great questions, so here you go. Question number one, I have essential tremors in my hands, head, and voice. I have been told my best option is DBS. Do you think this could help and be less invasive?
Yeah, so that's a great question, and I think the key element in that question is the voice and head tremor. And our experience is that those are really hard to treat. So we have dramatic success with the hand and arms, and frankly with leg tremor too, although that's less commonly an issue. But head tremor and voice tremor, I typically tell patients not to expect that that's going to get better. But to be candid, I don't know that it gets a whole lot better with DBS either. Both of them are really effective at helping with the tremor in the hand and the arm, which from a functional standpoint is a really big deal. But those things that are in the middle of your body, so think about the head and your voice, trunk, those are more difficult for us to treat either with focused ultrasound or DBS. So I would be a little cautious to think that head tremor is going to go away if you had bilateral DBS myself. And I do DBS and I enjoy doing it. Really, it's typically the upper extremity tremor that causes the biggest problem for the patient. And each person would have to decide if you feel like head tremor is really the only thing that's bothering you, which would be a little unusual, then maybe this wouldn't be for you. But if it's just one element of a bigger picture, which is most often the case, we don't hesitate to do focused ultrasound in those situations, just understanding that the head and the voice are probably not going to be substantially improved.
Great, thank you. Can you review again? I have been informed that only one hand can be treated. Is that true?
Yeah, so we can treat both hands. That's definitely the case now. The FDA approved that about, well, a little bit less than a year ago, and we started at the beginning of this year doing the second side. So the only caveat is we have to wait 9 months. So we can't do both of them at one time. However, we can definitely do the opposite side, and that's approved, and we've done, I think, roughly 30 second side treatments in the last several months.
Thank you. Next question. I have a pacemaker and cannot have MRI. What do I do?
Yeah, so if you have a pacemaker and truly it's not compatible with being in the scanner, then we're not able to do focused ultrasound. We do have patients with pacemakers that, working with the manufacturer of the pacemaker, we're able to do a scan, but there are some older models that we just can't put into the scanner. And in that case, focused ultrasound wouldn't be an option. Now, if you were running out of battery power on the pacemaker and it was replaced to a newer model that is MRI compatible, then that would change that scenario. But if the pacemaker is truly not able to be put into the MRI, which is a big magnet, and that's the concern, then DBS would be your other surgical option. It would be that or just continued medical management.
Can you speak to the prescription or the failure of medication? Because my primary care physician is the individual that takes care of me. So I just need to be better educated on the prescriptions that you talked about, beta blockers.
Well, I guess, so you're asking about how to manage those prescriptions or whether they are, or how they're effective they are, or what's, I just want to make sure I
Yes,
understand the question.
I think the way to interpret this is with the frontline medications. Can you explain propranolol and primidone? Is that an absolute must to be able to qualify for this procedure?
I gotcha. I don't consider it an absolute must that you have to have tried and failed both of those. Now, I do think we like to have seen a good faith effort, but depending on the patient, most patients, if they've had their tremor long enough and it's become severe enough, the medicines are just not going to adequately control it. Some people take propranolol or other beta blockers not only to try to manage the tremor, but they may be prescribed this medication to control hypertension or other, heart conditions, and that's a different story. You definitely need to take your medicine for that. Primidone helps some people, but it's also a medicine that is sometimes hard to tolerate. People get side effects from it, and that also counts. So if you can't take the medicine because you have side effects that are too severe or intolerable to you, then nobody expects that you have to try to take the medicine anyway. So that's a long way of saying it is best if you've at least had some effort at medical management, but realistically, as the years go by, for essential tremor, they're just not real satisfying.
And to complement that same question, can you speak to post-op and medication? Can I expect those same medications to be terminated or decreased?
Yeah, that's a great question. We get that all the time. So from my perspective, strictly as the neurosurgeon, and I almost hate to say this, you don't have to take the medicines, okay? But there are a couple of important caveats here. So let's say that you're, as was just mentioned, taking a beta blocker for high blood pressure. Well, you're not just taking it for tremor, you're taking it for another reason. And so you really need to talk to your cardiologist or internist who's prescribing it for this other purpose rather than stopping it. Now, if you're taking it for tremor, then the one other consideration would be, what's your tremor like on the other side? And do you find the medicine helpful? So if patients say, I'm only taking it for tremor and I don't feel like it's really helping me anyway, well, then just stop the medication. Or if you're really one-sided and the focused ultrasound has alleviated the tremor on the one side, the other side doesn't get in the way or bother you, well, then you don't need to take the medication anymore in that scenario. However, there are some times when maybe we treat one side, the other side's pretty bad. The medicine helps a little bit, not tremendously, but it helps some. You may want to continue taking the medicine for the untreated side until we can treat that second side.
Thank you. Is the entire head shaved, or or just a portion?
The entire head. I think you're muted, Dave.
My bad. Sorry. You have done 230 procedures. How many have had no or less than 10% improvement?
Uh, I should know that number, but I think I can count it on one hand. And the reason is that we screen for that up front with the CT. The only reason that people would not, in our experience, have improvement is that the skull is so inefficient that we're just not able to get enough ultrasound energy to the target. And because we're screening up front for that, we tend to just tell those people that we aren't going to be effective at treating up front. You really don't need to pursue this. So almost all of our patients, without exception, are getting better. Now, having said that, the skull density ratio, for example, is not the whole story. And I mentioned thickness and shape. So you can have a really good skull density ratio and still have a difficult skull. We can still get there, but we may have to use more power and more duration than we normally would. And then conversely, we've had some patients with a very low skull density ratio that was a little concerning, but they wanted to give it a try and we thought it was reasonable and they were remarkably efficient and did beautifully. So that's not the whole story. That one data point of skull density ratio is not the whole story. But to answer the question, I don't think we've had even 5 people that have gotten 10% or less relief of their tremor. But again, part of the reason is because if we think somebody's just not going to benefit, then we don't do it.
A lot of questions on the prescription front. Dr. Bonnen, I heard you say that one is a candidate if medications aren't working. If they are working, just not as much as I would like them to work, am I still a candidate?
Yeah, definitely. And in fact, that's really the most common scenario, is that people have really profound tremor. The medicine takes a little of the edge off the tremor, but it's still debilitating. That's most patients. They get a little bit of relief, but just not enough to improve their quality of life to the point that they can do the things that they would like to be able to do. So those are still good candidates.
Wonderful. You mentioned earlier talking about other items that could be used for treatment. I looked at Calitrio for possible treatment when mine were getting worse. What is your opinion of that device?
You know, my experience with that is more anecdotal, but I do have some patients that have found that it is very helpful to them, and so I'm a little agnostic on it and open to patients trying it. It certainly doesn't burn any bridges, so to speak. So in other words, if you try it and it's effective for you, wonderful. If you try it and it doesn't give you the relief that you're looking for, then we're still able to do focused ultrasound or DBS or anything else. So it's not a bad thing to try. And I have had some patients tell me that they did get relief, from that treatment.
Gotcha. I have a small piece of wire in the front left of my skull. Will this prevent you doing focused ultrasound?
We'd have to look at it. We would probably look at the CT scan and maybe even just some plain old x-rays to get an assessment of that. It wouldn't be an absolute contraindication. The main concern is, frankly, how much artifact might it create, and is it firmly embedded so that it's not going to come out? So again, the MRI scanner is a big magnet. So things that are not secured, that are metallic, could literally fly into the scanner. I doubt that a small piece of wire would fall into that category, but we'd have to take a look at it. My hunch is it would be okay, but we would have to evaluate it.
Thank you. Questions keep coming. Once, if I were to commit to the procedure, what would the time frame be to have the procedure actually done?
It's usually a few weeks. And then now, of course, it's not an emergency or an urgent thing, but at least from the surgeon's perspective, some patients find it very urgent. But by the time that we get the head CT done and get everything scheduled and coordinated, I would say that usually takes a few weeks for us to do. But it's not months or anything, so there's not like a 6-month wait to be able to get this procedure done. But we have a great staff. Give them a little bit of time to get the approval with the insurance, get the head CT done, and to get you on the schedule. So I'd say it's in the order of weeks.
Okay. Another question regarding medication. I noticed that this treatment is only used after medication treatment. How does this treatment start? So I don't know if that's an interpretation of, do I need to go to a neurologist for medication first? That's kind of
Yes.
my interpretation.
Yeah. So we're happy to evaluate patients whether they have already been seen by a neurologist or not. It is helpful, but not required. Okay, if they've seen somebody else, and we have plenty of people that come directly to us, and that's not a problem. It is, I think, a commonly accepted best practice that we would make some effort to treat the patient with tremor, but there's a more complex story to that, and that would be typically the tremor begins insidiously and it's more modest, it's more mild. It may start as an irritation or a nuisance and not be something that's truly debilitating. And so naturally then in that case, people aren't going to jump to having a surgical procedure done or a focused ultrasound. And so they start with medicine. And then as the years go by and the tremor becomes a little more severe and the medicine isn't as able to manage or to treat that, then they come to us. So that's a more of a normal time course. Now, there could be a scenario where somebody has really profound, severe, debilitating tremor. They haven't been on medication. We can try it, but at that point, I can already tell you it's not going to be able to control a really severe case of tremor. So I think it just depends. It's a case-by-case basis, but we're not going to refuse to evaluate somebody because they haven't seen a neurologist or had an opportunity to be, trialed on medicine. And if anything, if they were not an appropriate candidate at this time for focused ultrasound, we'd help them find somebody that could treat them with medication.
All right, very nice. This is a good one. What recommendation would you have if your tremor is worse in my non-dominant versus my dominant hand?
Yeah, so we do run into that. And obviously, it's really easy when the tremor is most severe in the dominant hand. So you're right-handed, the tremor is worse on the right, then we're going to treat the right side. If you're left-handed, it's worse on the left, we're going to treat the left. There are scenarios where somebody is, let's just say, for example, right-handed, but the tremor in the left hand is just 5 times worse than in the right. Well, we'll treat the left side then. And that really comes down to a very practical decision of what's going to give the patient the most benefit and what's going to do the most to improve their quality of life. Now, a little different scenario would be there's tremor on both sides. It's actually a little bit worse on the non-dominant side, but it's not very good. It's actually kind of bad in the dominant side, just not as bad. In that case, we might go ahead and treat the dominant side because they're just really right-handed or they're really left-handed, and they're just going to get more benefit from being able to better use their dominant side. So it becomes a very practical question of which one is going to make your day-to-day life the most improved.
Okay. Another question regarding implant. I have a mechanical heart valve. Can I receive treatment?
Yeah, I think that in most cases, the answer is probably yes. But what we do with all implants, whether it's a heart valve, pacemaker, any other type of implant in the body, is we run the traps on that. We will literally get the device, the number that identifies the device, will track it down with the manufacturer and make sure that it's compatible. The key is it has to be able to go into the MRI scanner. And if it can, no problem. And now if it can't, then we can't do the procedure.
Question is treatment different for essential tremor as defined versus tremor dominant Parkinson's?
So the well, okay, this is a little bit longer answer. With respect to tremor, so if we're just treating tremor, whether it's from essential tremor or tremor dominant Parkinson's, we are doing the exact same focused ultrasound procedure. That is the same. Now, and so I think that most directly answers the question. Having said that, I'll tell you that there are some patients that, let's say, have tremor dominant Parkinson's, and they've got more than just tremor. And they're starting to experience some difficulty with their gait, maybe a little bit of difficulty with their fine motor skills. They've got other symptoms besides tremor that are significant. There are other targets in the brain besides the thalamus that could be more beneficial to them. And long term, they might do better with DBS. And so that would be a consideration. But for our tremor dominant Parkinson's patients that really are predominantly affected by tremor, don't want DBS, aren't worried about a lot of the other symptoms, this focused ultrasound procedure is exactly the same as what we do for essential tremor.
Right. We got a handful of questions left. They've been great. Can you speak to treating head tremors?
It's frustrating because we don't have, in my view, a really great treatment for that. There's some people that think that bilateral DBS maybe can be effective at treating head tremors. I wouldn't say that focused ultrasound is highly effective for head tremor, and we've had a great experience with DBS for tremor, but again, not so much when it comes to head or voice. And so that's just one of the more frustrating symptoms that some people may get when they have essential tremor.
Great question here. Kind of hits home. Can you speak to basically the genetic component of essential tremors? I have first cousins with ET. If it works for me having it done, what is the potential of it working for them?
Oh, I think it'll work well, without a doubt. And that's very common. We actually have had family members who will nominate the first patient, the first candidate from the family to be treated as the guinea pig for the rest of the family, and then other family members have come on in, and we've had in one case recently guys that were best friends since high school, and they did it differently. They decided, and it's not hereditary because they're friends, but they came and had their treatments on the same day together. But the short answer is it would help other family members, provided, yes, we're treating essential tremor. And it's super common that many of these cases are hereditary. So no problem treating those.
Great. Is there a severity test to qualify for the procedure?
So we have a pretty extensive questionnaire, and then part of that questionnaire is what some people may have seen, where they'll draw spirals. You saw that in the presentation. So you'll draw spirals and straight lines, and then write your name. We'll also have people pour water from one cup to another, which some can do. Some can't even manage to do that without getting water everywhere. And there's actually a rating scale where we numerically add up the score for the patient's tremor. And there's a little bit different scale that we'll use when patients have Parkinson's disease. But as a practical matter, I find that the rating scales or the severity really correlates with the patient's experience in day-to-day life. And if it gets to be bad enough that they're having a hard time functioning, then it's more of a formality of just documenting that in an objective way. It's not a pass-fail test where you're not going to score high enough on the test to be able to be treated. So it doesn't become a barrier or an obstacle. It's more of an effective way of objectively documenting what we could see in 30 seconds of examining somebody in the room or on a video. How do you put that onto a piece of paper? That's what these other ratings do. But it almost never becomes an issue in terms of a decision point. It's just really more of a form of documentation.
Gotcha. We've got 3 questions left on the board just to give you somewhat of a timeline. Here's somebody pretty well educated, likes to look at the clinical side, look at studies. I looked at some studies and saw less tremor reduction than you are achieving. Is that because surgeons are just getting better at this treatment?
That's a good question, and I'm not certain about that. I will say that I do think we have a couple of things that are helpful. One is that, look, this is a great technology, and I would be confident that any neurosurgeon who really invested in getting up to speed with it could use it. However, having said that, it helps that in this case, I've been treating movement disorders surgically since 1995. And so this is like riding a bicycle. When you've been targeting this area for 28 years, just using different pieces of equipment and different technologies to do it, you more quickly are able to pick up on that. And then with this specific equipment itself, it's really amazing what we're able to do. And the technology drives a lot of it for us in a very positive way. But having said that, I can tell you that our efficiency and my confidence level and the effectiveness of our targeting is honestly better after 200 cases than it was after 20. So experience does matter in terms of some of the nuance associated with it. And then the final piece, which is even more detailed, is that the ultrasound transducer and the software and all that may be the same. The scanners are different, but I would almost compare it to this is a terrible analogy, but say a baseball bat. If you're a professional hitter, Major League Baseball player, you could probably pick up any bat and be better than almost anybody else. But that doesn't mean you don't have your favorite bat. And it doesn't mean that you don't like the pine tar adjusted in a certain way. And you have your own little, touches that really make you just even a little bit better. And so for some of us, just getting used to using our equipment, like I could go and I could do this procedure in another hospital and do it well, but I know how my equipment on our scanner is going to behave from experience. And it may be a little different on a different setup with different equipment in a different facility. So that's kind of a long-winded way of saying that it's safe, it's effective, but experience does matter. And I do think that that can have an impact on, to some degree, on the quality of your outcomes.
Great. I love your baseball analogy. Perhaps our Houston Astros were listening in. So, individual asked about if you would touch again on Parkinson's and specific the anatomic area that could be used with focused ultrasound for Parkinson's.
Yeah. Okay. So I apologize. The sun is starting to come through the window. We, due to this daylight savings change here, I hadn't accounted for the sun coming through the shade. So I'm sorry if that creates a glare on my finely shaved head here. But so this gets a little bit complex. There are 3 targets in the brain that historically we've used to treat movement disorders. One would be the thalamus, which is really what we're talking about predominantly now, whether it's focused ultrasound or DBS. However, the globus pallidus and the subthalamic nucleus are 2 other targets in the brain that can be highly effective at treating patients, particularly patients with Parkinson's disease. So this technology is approved for use in the thalamus for tremor. It's also been approved to perform a focused ultrasound ablation in the globus pallidus, which is something we would do for Parkinson's disease. Now, a frustration that I would have right now at this point is that it's only with respect to the globus pallidus, I think approved for treating one side. And most Parkinson's patients end up being fairly impacted on both sides. The other issue is the FDA has approved it for treating the globus pallidus in a Parkinson's patient, but I don't think Medicare is paying for it yet. And so you can have FDA approval, but if there's no coverage, and it's, we can do it for a cash price, but it's still expensive. That becomes an access problem or a barrier to treatment. And then the third target, the subthalamic nucleus, is a really great target for patients with Parkinson's disease. But we're putting stimulators down to that target, and there's a lot of concern about potential risk if you were to do an ablation there. And I'm not saying it's impossible, but it's not something we're really comfortable doing right now. My father actually had Parkinson's, and in fact, not long after I started into this in the mid-90s, my parents came over to the house and were talking about some of the problems he was having, and I actually was the one who diagnosed him with Parkinson's, and that led to a whole journey where he actually had DBS, and it really made a difference in his quality of life for a number of years. But unfortunately, that's a really tough disease that progresses as time goes by. But there are 3 different targets that we'll typically use. This technology is typically used for the one that's best for tremor. If we ever got the payers to cover the globus pallidus and then maybe got permission 9 months later to do the other side, I think that could be a bit of a game changer in our surgical treatment of Parkinson's, but we're not quite there yet at this time.
Okay, we are at 1 hour, and I tell you, those were a number of great questions. So I want to thank you, Dr. Bonnen, for a great overview and discussion with our audience. I will also go back to this piece that the slide we have right now is very informative. And when Dr. Bonnen talked about his team, they're very efficient, they're very thorough, and the hands-on is just outstanding. If you visit the website, HoustonPhysiciansHospital.com, there are 2 tabs within that website that you can navigate to get additional information regarding focused ultrasound. First one is under the specialties tab, and the second one is under programs and services tab. So Shalene and or Maddie, anything additional from the 2 of you?
Nope. Thank you very much, Dr. Bonnin. It was great.
All right. Thank you, guys. I enjoyed it.
Great. Thanks all.
Bye.